All right, welcome everyone. Just a little bit of background information on RHIP before we get started. So RHIP is a project supported by the Health Resources and Service Administration and the Federal Office of Rural Health Policy. Janine Myers is our RHIP project officer. Then our purpose, RHIP is designed to help strengthen organizational foundation and the key elements of value-based care, including efficiency, quality, patient experience, and safety of care. And our goal is to guide small rural hospitals and certified rural health clinics not currently participating in value-based care through advanced alternative payment models to prepare for and position their organization to be effective participants in a health system focused on value. And now we'd like to welcome today's speakers. We have Marie Berry and Ken Carlson. Marie Berry currently serves as Director of Community, Economic, and Workforce Development at the Rural Wisconsin Health Cooperative. She leads efforts to utilize one of rural communities' greatest assets, their hospitals, as a driver of economic development. The Rural Wisconsin Health Cooperative is a cooperative of 40 hospitals, 40 rural hospitals across Wisconsin that has provided shared services and acted as an advocate for our member hospitals for over 40 years. Marie has previously worked for 2 senators in the Wisconsin legislature and successfully shepherded bipartisan bills from drafting to being signed into law, including during split party control of the legislative and executive branch. And Ken Carlson is Vice President of Business Development and Planning at Sauk Prairie Healthcare in Prairie du Sac, Wisconsin. He is responsible for data analytics, strategic planning, new business development, addressing community health needs, project management, and facility planning. During his Sauk Prairie Healthcare tenure, he has provided administrative oversight for several departments, including marketing and community relations, facilities and environmental services, foundation, clinic practices, rehabilitation services, wellness center, and quality and patient safety. Thank you both very much for speaking today. We're really excited about what you have to share. I am going to stop sharing and hand things off to Marie.
Great. Thank you, Molly. I'll get my slides up here. Great. Okay, so as Molly said, my name is Marie and I work for the Rural Wisconsin Health Cooperative. And today I'm here to chat a little bit about rural hospital engagement and economic development, why and how. I kind of work at the intersection of these two fields, healthcare and economic development, which oftentimes gets me a funny look depending on what room I'm in because people don't understand how those two relate. So we're going to share a little bit today about the intersection between these two fields and then how a lot of our hospitals in Wisconsin are taking action to improve economic conditions in their community. So a couple of disclaimers before we get started. The first is that I'm going to share a lot of examples with you today. And it's important to know that as a cooperative, we are member owned and operated. So a lot of the good work that I have the pleasure of sharing happens on the ground through our rural hospital members, and it's their own work. And I don't mean to claim credit for it, but just hopefully share it as a source of inspiration for you guys. And then I also just wanted to share that the content of this presentation has been edited to comply with 2 recent executive orders. So I will get started with that. I can advance my slides. So as I said, RWHC is comprised of 40 rural hospitals across the state. 34 are critical access hospitals and 6 are PPS hospitals. So hopefully that gives you an idea of kind of the scale of these organizations and the communities that they're located in. And hopefully it feels very familiar to many of the individuals on the call today. So why are we talking about economic development in relation to healthcare? I think the easiest way to start having this conversation is to think about the patient experience within our hospitals, right? So all of our hospitals provide clinical care. That's why we exist. That's why we're present in communities every day. Most of our hospitals also screen for individual social needs. So we ask questions like, have you been hungry and unable to afford food? Did you have transportation challenges getting to your appointment today? Or will transportation hinder you from getting to further care that you need? And when we ask those questions, we're really thinking about an individual's social needs on a personal level, right? We're not thinking about the system or the community that they live in. We're just thinking about them as a unique individual and making sure that we can help meet those needs that interact with their health outcomes. But what I'm hoping to talk about today are the community conditions that people live in, right? So when we ask someone, are you hungry and have you experienced hunger and been able to and been unable to afford food, oftentimes that relates to, are there good paying job opportunities in the community, right? Where people can make enough money to meet their basic needs? Do we have a grocery store present in the community that sells healthy, fresh food at an affordable price? Do we have adequate transportation systems within the community that help people get from their home to places that they need to be, especially if they're disabled or elderly or otherwise unable to drive themselves? So, thinking today from a systems level perspective, we're going to talk about economic development as a tool to address social variables in communities and change community conditions. So, you'll see that the examples I'm going to provide today really occur at the systems level and not the individual level. So, moving beyond those individual health related social needs and thinking more broadly at a community level, how we as hospitals can use economic development as a strategy to change broader community conditions that impact health. So why should you care, right? Oftentimes when I talk to hospital leaders about this, they're like, yeah, that's great, but I can't find enough nurses to staff my ER, and my orthopedic surgeon's leaving next month, and I have like much more pressing things on my plate. So why should I add this additional duty of thinking about economic development in my community to my plate as a healthcare leader? And there's two ways to answer this question, right? The one is the impact that your local economy has on your hospital, and the second is the impact that your hospital has on your local economy. So we're going to go through kind of what the research tells us about this, and hopefully it will show you that they're pretty inextricably linked. So whether we like it or not, the economy in our community is going to impact our hospital and vice versa. And when we're aware of that and proactive about it, it often leads to better outcomes for both organizations. Okay. So the first perspective we're going to talk about is the effect of the local community on a hospital. One kind of like disclaimer I wanted to throw out there is a lot of the research that examines the effect of the community on a hospital is related to closures, right? Because when a hospital closes, we have kind of definite data, right, that the conditions in that community were not hospitable to the operation of a hospital. So I think keep in mind that some of this research is also applicable if your hospital is not facing closure but is just struggling financially or struggling to find sustainability as an organization. So rural areas are more likely to experience lower income, lower educational attainment, fewer employment opportunities, lower housing quality, and higher transportation barriers. Obviously, rural is not a monolith. Every community is unique, and so this is not universally true of every community, but data tells us that in rural communities, where people are more often struggle to find high quality job opportunities. They are less likely to graduate from high school or to obtain a bachelor's or master's degree. We oftentimes have higher unemployment rates. We see older housing stock, which often relates to poorer housing quality, which has a large impact on health outcomes. And higher barriers to transportation, right? It's very rare that living on a rural road like I do amidst the cornfields, I'm not going to see a bus rolling by anytime soon that can take me into town to get medical care, buy groceries, go to a pharmacy, etc. So economic development is a strategy that can help us as hospital leaders begin to tackle some of these challenges that we see within rural populations. What we know from research also is that rural hospitals at risk of financial distress were more likely to close if their community had higher unemployment rates or higher uninsurance rates. So, helping to attract high quality jobs to a community can help stabilize a hospital by offering more individuals who are commercially insured and kind of bolstering the payer mix of our local hospital. Additionally, many rural areas are shrinking. This is not universally true. We have a lot of kind of outdoor recreation communities that are growing post COVID, but rural America as a whole is losing population. So, rural population loss means fewer births, right? Lower volume in our obstetrical units, more deaths, and more people leaving than moving in, which can lead to workforce challenges. So what does this mean as a whole when we look at it from the perspective of a rural community and the interaction with the hospital? So if we have an aging population, we often have higher utilization of healthcare services and more chronic illnesses that people are managing. If we have a shrinking population, that often leads to lower volumes in our hospital, which can make it more difficult to sustain services. And for a community, when we have aging and shrinking populations, this leads to less workforce and economic activity. So, one example from our state, the number of people living in Price County, Wisconsin, fell about 5% from 2010 to 2018. And in that same time period, there's a 12% drop in the local workforce. So I know many of our hospitals in the state workforce is one of the number one issues facing their communities. So taking action as a hospital to kind of stem some of these aging and shrinking population trends can be really important. Um, and finally, when we see less workforce and economic activity, that leads to more uninsured patients or more patients on Medicaid and lower reimbursements for our hospitals. And then we can flip this and also think about the effect of the hospital on the local community. So first and foremost, right, we provide care. We provide high quality clinical care, which is important to the residents living within our community. But we also have a much larger economic impact than just receiving care. And this is a conversation that I think is often missed in rural communities. When people are thinking about closure or consolidation of rural healthcare, they're like, well, we have another hospital that's maybe 20 minutes down the road. It wouldn't be tragic if our hospital here was unable to offer X service anymore. But what we lose often in that conversation is that healthcare workers have consistently higher wages than the average worker in non-metropolitan areas, meaning that they're high quality, high paying jobs that bring money into our small rural places. Also, healthcare jobs are projected to grow, so they're a growing source of employment in rural counties. And finally, there's a number of other economic spillover effects from having a small hospital present within a community. It increases local retail sales. It increases the number of retail establishments. It generates taxable local retail sales, which helps our local governments remain solvent. It creates local jobs and other local business activity from kind of the spillover economic effect, right? We employ a large number of people. We have high paying jobs, and those people go out into the community and spend their money accordingly. So the economic impact of retaining healthcare in your local community really cannot be overstated. And finally, the flip side of this is that we know when hospitals close, we're not only losing access to clinical care, we're also seeing kind of a decline in the economic health of that community as a whole. It reduces the local income per capita, it increases unemployment rates, it increases poverty rates. Oftentimes we see decline in rent values, and we see the decline in other non-healthcare occupations throughout the community. So just one example to kind of illustrate this connection between local economic conditions and the health of a hospital I wanted to offer for you guys. So the picture here is Southwest Georgia Regional Medical Center in Cuthbert, Georgia. So I grew up in rural Georgia and now live in rural Wisconsin. So that's kind of why I chose these two hospitals as an example. And I know that there have been some conversations about reopening this hospital in Georgia, which is wonderful and hopefully will happen. But anytime that a hospital closes and we experience that disruption of healthcare within a community, it can be really challenging and tragic for residents. So you see these two cities have a very similar population. They have similar unemployment rates. However, you see that the community in Georgia has about half of the median household income versus the community in Wisconsin. Their poverty rate is more than double the community in Wisconsin, and the number of individuals without healthcare coverage is almost double digits. The hospital in Georgia, as I explained, unfortunately had to close their doors for a period of time. Hopefully, we'll be able to reopen soon. Whereas the hospital in Wisconsin was really excited. They announced at one of our recent board meetings that they had a positive operating margin in their last fiscal year and were able to share that back with staff and some bonuses for performance. So hopefully that helps illustrate how these community conditions that we often see as like out of our control are super integral to the operations of our rural hospital and are something that as hospital leaders we should think about and actively take a role in trying to make better. Finally, economic impacts of hospital closures, decreased income, decreased population, decreased economic growth, and increased poverty. So really is for the best for our communities if we can retain local healthcare services. But how do we do this, right? This is always the question. People are like, okay, that's great. Thank you for, reading to me from a bunch of academic literature for individuals who don't do this on the ground every day. What am I, as a small rural hospital leader, supposed to do about this? So I'm going to offer some examples from some of our rural hospitals, and then Ken is going to jump in and share about their specific hospital and what they've done to grow stronger relationships with local employers and help keep more healthcare local within their community. So I always share these examples. The example on the left is from Portland. The example on the right is from Denver. And these are two large urban healthcare organizations that noticed they had housing challenges within their communities and decided to take action on them and built these beautiful housing developments, which is wonderful for their communities, but I think can often be discouraging for rural healthcare providers when they say, okay, but our community has the same problem and we don't have, a spare $20 million laying around to build a beautiful new housing development. So what can we do with the resources that we have available to us? So the first that I always like to start with, because it is free, is acting as a convener. I had a conversation when I first started this role about 4.5 years ago with a CEO at one of our hospitals who was kind of managing a financial turnaround of their organization. And he called me and he said, "Hey, Marie, we have a housing problem in this community. I don't know what to do about it. I have $0. Like, where should I go from here?" And I'm an eternal optimist. So I was like, we can do something with that, right? We've acknowledged there's an issue. We're willing to take action. And even if we don't have financial resources, we can create change. So what he did is pulled together about 20 to 25 of the largest local employers in a very small community. He brought them into the hospital over lunch, fed them lunch, told them a little bit about the changes they were undertaking at the hospital, asking for their support to make sure that their employees were utilizing local healthcare services, and then pivoted into talking about housing. He talked about how it was a barrier to their workforce. Many other people in the room spoke up and said they had similar challenges. If they were able to recruit employees, there was nowhere for them to live, etc. They were able to get together as a coalition and talk to their local leadership about housing challenges within the community. And so the mayor and city council ended up commissioning a housing study. So they had up-to-date market data. They took that market study then and were able to apply for some external grant funding and work with a developer, and recently had a beautiful workforce housing development, multifamily development open in their community, right? And that cost those employers no money, but it was just a matter of someone stepping up, convening the group, bringing them together, and starting the conversation to create change within the community. I've seen this work really well with childcare as well, another large issue impacting healthcare workforce. Oftentimes, hospitals don't have the capacity to own and operate their own child care center, nor do they want to, but they can bring people together, host a conversation, and start to figure out what, as a community team, you can do to tackle some of these issues. The next strategy is thinking about your organization as an anchor institution. So, anchor institutions are organizations that are place based, right? As we saw in the Midwest years ago, a lot of manufacturing organizations have the opportunity to leave, right? They don't necessarily always have to operate in the one town they're located in. They can say, you know what, we've decided to outsource production to insert country here. What we know is that schools, local governments, hospitals, et cetera, are place-based, right? You've never seen an organization that, we'll use an example in Wisconsin, Reedsburg Area Medical Center is not going to stand up tomorrow and announce that they're moving their hospital to Arizona, right? They're kind of subject to the economic reality of their community, be it good or bad in the future. And so anchor institution strategies bring together all of these place-based organizations to operate in a way that helps strengthen the place where they're located. And this is done through hiring locally, sourcing locally, and investing locally. So I'll offer some examples of how our organizations have done this. So hire locally. I think for a long time as healthcare organizations, we had the privilege of being highly sought after jobs within communities. We could post jobs and wait for the applicants to come to us. And I think this is no longer the reality in most organizations, given the demographic changes that we're seeing, right? We have to really intentionally build talent pipelines through partnership with our K-12 organizations, our technical colleges, all the way up to our medical schools within our communities or within our states. Um, and the opportunity that comes with this, right, is we have an opportunity to grow our own talent and to give residents within our own communities the chance at high paying, high need jobs. So one of our hospitals, for example, has really intentionally crafted um, talent pipelines around MAs, CNAs, paramedics, EMTs, lab techs, and surgical techs. So partnering with high schools and technical colleges to find interested individuals who live in your community and would have an interest in these job roles, and giving them really clear paths to the education they need to fill these vital roles within our hospitals. And we've seen this also with creating our own physicians, right? What we know is that if we take a kid from a rural area, we put them through a really focused medical college track, and then they complete a rural training track in their residency, that they are 80% likely to practice in a rural area. And given the rural physician shortage we're experiencing, this activity is kind of more important than ever. So a large number of our hospitals have stepped up to offer rural rotations and even create rural residencies to help train and retain physicians in rural communities moving into the future. The next part of an anchor institution strategy is purchasing locally. I think our hospital in Stoughton is a great example. So they did a purchasing scan of their organization a couple years ago to kind of garner more awareness about where they were spending their money. And through that process, they realized some simple small things. Like, for example, most of the food that they were using in their organization was coming straight off of the Cisco truck. And so now they've partnered with a bakery on Main Street, and they buy all of the baked goods that are used in their hospital, both to feed patients and that are available to staff and the public, kind of in their cafe area, from a Main Street business. So they're spending that money as close to home as possible and making sure to support local businesses and local jobs. Um, and you can do this in a variety of ways through the contractors that you use for construction projects, the swag that you offer to your employees, what you sell in your gift shop, like some of these really low-hanging areas where we can think about trying to recirculate more money within our local economies. And on a broader scale, we've also seen this done through food hubs. So the Fifth Season Cooperative is one example where they were trying to grow their local food system. And in order to do that, they needed kind of the farmers and their processors in their area to have more market certainty, that if they made investments in production, they would definitely have a market in which to sell those goods and receive a return on investment. So there were a number of hospitals and school districts and other local organizations that made purchasing commitments that made those growers and processors able to invest on the front end in their local food system, knowing that they would have a purchaser on the back end. And those hospitals and school districts in return knew that they were putting their money into local businesses, strengthening their local economy, and oftentimes receiving more culturally relevant food for their food programs within their institutions as well. And the final piece of this strategy is investing locally. So thinking about impact investment as a way to redeploy dollars within our community to have not only a financial return, but also a social or economic return for our community. So one example of this is Fort Healthcare, which is a hospital within our cooperative, recently made a $3 million investment in a local fund meant to serve as gap financing for housing development in an area in need of new housing. And their CFO, who's been at the hospital for, he jokes he's like a dinosaur. He's been there for a million years. He's very, very well respected. And he presented about this to our board of directors, and people were kind of like, well, how did you decide to, take this big risk? And he was like, this real estate is often a part of our portfolio anyways, right? Through real estate investment trusts and other mechanisms. And he's like, this makes sense because we know that we're changing conditions in our community that impact both our staff and our patients, and we're still receiving a financial return. This is not a donation, this is an investment, but we're also seeing positive impacts within our community. One of our other CEOs who was working with his board on an impact investment policy, in a moment of frustration, said the words, "Amazon does not care about our community." And I thought that was kind of poignant, right? Oftentimes we think our local community is risky, when in reality, our hospital investment portfolios are sitting in the hands of large Fortune 500 companies that have not historically acted in ways that are favorable to rural communities. The next strategy to talk about is building strategically. So oftentimes as healthcare organizations, we're making large capital investments into our communities, and the way that we go about those capital investments can be changed in order to have a larger economic impact. So this is an example from a really small community called Elroy. They have a nearby hospital in Hillsborough who is looking at putting a new clinic within this community. They had an existing community in sort of like a mobile home building that had been in the community for a long time, but was in really poor shape, and decided it was time for a new clinic within the community. This community, 20% of the individuals in the community live in poverty, and 25% are below the ALICE threshold. And as you can see, their downtown is probably not winning awards anytime soon. So as an organization, they were trying to think about, we know how to provide high quality healthcare, but how do we impact other economic determinants that are impacting our patients' health outcomes? And through that conversation, they decided to build in the downtown and really kind of provide an economic spark to that community. For anyone who has been through a capital project, I think you can look at that site and know it was far from ideal, but to them, they felt like the economic impact it would have on the community was worth it. Um, so they built this building, which I believe here you can see it in the beautiful Wisconsin snow when it was open. In order to do that, they closed part of a road, they leveled the site. They had a really deep partnership with their municipality who was really excited about this investment in the downtown. They invested in renewable energy on site, so it actually has been paying them every month versus them having to pay a utility bill, which is huge for the long-term financial sustainability of this location. It includes a community room that organizations can use after hours. And it's been really inspiring to hear them talk about kind of the change in the downtown since this investment was made and just seeing more people, more cars, more foot traffic, other businesses downtown, seeing more customers come in and spur local economic activity. Their board chair is a dairy farmer and veterinarian in the community, and he gave a really poignant speech at the ribbon cutting about how healthcare is a driver of economic development in rural places. And it was really kind of impactful to hear a lifelong community resident talk about the importance of healthcare acting as an economic driver within these communities and seeing kind of a champion for that mindset among a board leader. And their CEO always says economic development is population health. And she's a really fierce advocate for their community. She was born in that hospital and has raised her 3 kids in that school district and will grill people when they come in about like, are you staying in our local hotel? Did you go downtown and check out our local shops? Like she is a real champion for that community. The next strategy is thinking about advocating and educating on economic issues. So oftentimes as healthcare leaders, advocacy is just part of our job, whether we like it or not, right? Often through our state hospital associations and other professional groups, we advocate on the state level, on the federal level, and oftentimes we should be thinking about also how to use those advocacy skills on the local level. So this is an example. Brian Stevens is the CEO of Door County Medical Center, a critical access hospital in northern Wisconsin. And they made a point or a commitment, I should say, as their leadership team to attend any sort of plan commission or other local government hearings about housing. And the reason they did that is because housing has been such an acute need among both their patients and their workforce, and their community has sort of had a not in my backyard mentality about new development. And so they wanted to kind of make sure the other side of the story was being heard within their community. And make sure that people understood the impacts that the lack of housing was having on their workforce and their ability to provide high quality care. So this is a picture of him at a plan commission hearing for a multifamily housing development, sharing about the fact that they have an x-ray tech living in a storage set and an inpatient nurse living in the back of a yoga studio to help make clear the realities of housing shortages for their organization and to advocate for local policy change. They have a really strong online presence as a hospital and have used that to kind of educate the community about how housing shortages are impacting them as an organization. And the final strategy I want to talk about is leveraging existing assets, right? So I hear time and time again from especially like small rural critical access hospitals, we don't have a lot of money. I don't know how we're supposed to change things within our community. And I would just challenge you to think creatively. So one example, one of our hospitals had extra land on their campus, and they were able to donate a portion of this land to their local technical college, and the technical college is building a cottage-style affordable housing development coupled with a flexible training space that they can use as a mobile training site for multiple programs through the technical college. This will provide needed workforce housing in the community and greater access to educational services. And, in theory, that costs the hospital very little money. They already own the land. They've owned the land for a number of years, but the donation of that land was really critical to getting this project off the ground, and it probably would not have occurred without it. Another example, one of our hospital leaders donated his time as a chief information officer and kind of IT expert to a county broadband committee. So able to use that expertise to help the county write for broadband expansion grants and secure over $2 million in additional broadband investment into the community, right? That's a pretty minimal cost to the organization in terms of just volunteering expertise, but a big return on impact to the community. Another organization, the hospital in Hillsborough, Wisconsin, their marketing director is super creative and has lent some of his expertise to their local chamber of commerce to help them get a logo and get a website and get up and running. He also does a large amount of grant writing for community-based organizations for free. So as a hospital, they don't have the money to solve all of the problems in their community, but they've leveraged expertise internal to their hospital to help community organizations go after additional resources. So, for example, they make a small donation annually to the local food pantry. And when they were delivering that donation, were informed by the food pantry that they were very appreciative of the donation. However, they needed a new roof, they needed some new freezers, they were having significant infrastructure problems within the organization, and they were able to help them write a grant to secure funding to get new freezers, to get a new roof, to kind of meet these infrastructure needs. And that again came at a pretty small cost to the organization of just their time and talent. So I am going to turn it over to Ken now to talk about how Stock Prairie Healthcare has taken action on growing partnerships with their local businesses.
Thanks, Marie. Can you see the PowerPoint presentation?
Looks good to me.
Great, great. Hopefully I can get this to work. Well, you covered a lot of great territory there, and it was, I appreciate Marie's coverage of so many of these examples in Wisconsin. I've been at Stock Prairie Healthcare for 25 years, over 25 years now. But prior to that, I had worked with 10 of the hospitals in Wisconsin as a management and planning consultant. And I worked with a company that worked with small and frontier hospitals throughout the nation, but again, many of them were based in Wisconsin. So I appreciate kind of looking at what some of these organizations, some of which I worked with directly many years ago, are doing, and it's great stuff. With that, I would like to just make sure I get out of the way the fact that this presentation also, like Marie pointed out, complies with the executive orders. So you'll see a couple of things that are blurred out for that reason, but that's not germane to the topic. So I'm gonna focus today on a couple of things that we are early on in with regard to connecting with employers. But as Marie was covering some things, I couldn't help but think of some of the things that aren't specific to my presentation that we're doing here at Sauk Prairie Healthcare. For instance, reaching out to the community by providing, if somebody volunteers 8 hours, we provide a PTO of 8 hours, and how do you connect with the community, that sort of thing. Making sure that we're hosting food trucks at our organization for local food trucks and those sort of things. So a lot of neat ideas that she shared. So I'm going to go into this, and the first thing I want to do is make sure that did that slide transition? We're good? Okay, great. I have a couple of slides that just talk about our organization. I'm not going to spend a lot of time. The one thing I did want to point out is that compared to some of you, Sauk Prairie Healthcare, it may be a little bit different. And I'll admit, to some degree, we're more advantaged than maybe more remote places because we're located near Madison, Wisconsin, and essentially in that economic umbrella of Madison, which makes us one of those counties that when Marie had shown the state of Wisconsin and there's a dark green, that meant there was population growth. We are advantaged by that. We are one of those counties that economically and population growth wise is doing pretty well because of our proximity. We're only about 25 miles outside of Madison, Wisconsin. So to some degree, a little bit of an advantage there. We are not a critical access hospital. We qualified to be one, but we are not, but we have rural health clinics. So we're still in a rural market. Yeah, this kind of gives you a sense of who we are. We were founded in the mid-50s and are locally governed. We are not part of a larger system. We do have four clinics that are not in the communities or not in the community that the hospital is located in. So we have a hospital and then four surrounding clinics, as well as some specialty clinics. Um, and again, just a snapshot, we have a service area that the pink part is about 45,000 people. That's our primary service area. So we're right there in the blue H, and then we have the four red crosses that surround us where we have clinics. And then the greenish area is kind of that next level out where we do get a fairly significant patient draw. And then that purple area, we have a very strong orthopedics program, and so patients come from pretty far away. Um, uh, and that whole purple area is, approaching 1 million in population, but our smaller area is about 700 square miles. So specific to partnering with employers, when we developed our strategic plan last year, there's two things I want to point out. The first one is in the vision statement. We aspire to be a national leader in community engaged healthcare. And we actually have measurements that indicate when we are a national leader. When we are comparing ourselves against other community-based hospitals, how do we stand up in terms of quality and patient safety, employee engagement, patient engagement, and from a financial standpoint. So those are the sort of things that when we reach a top echelon in all those four things, we will have said that we have accomplished this vision. Part of the way in which we need to get there is we focus on our strategic goal called access, which is really about making care seamless, and making it easier for people to access care. So let's drill down on that. Now, this is maybe a little hard to read, but I'll just read it verbatim. Identify and collaborate with area employers, private sector entities, and providers for other providers for opportunities to conduct research and pursue new approaches for patient access and other community health priorities. In fact, one of the things was we've been in this hospital now since 2014, and we vacated our former hospital, and we just now are working with a developer to redo that site into housing, although we still maintain some services on that site, and we will continue wellness and rehab. But that's it's about 6 acres that we are going to turn over to this developer to develop like housing. They will own it, we will not. But the point is housing, part of our community health needs assessment, is really critical there, and so we're facilitating some of that. But as it relates to employers, this excerpt from our strategic plan shows that what we want to do is really focus on working with employers directly. And that's essentially meaning that we're trying to remove the middleman of the insurance company. So one of the things that we have in place is what we call our campus clinic. That's kind of like the fifth primary care clinic. I showed you those red crosses. Well, this is a very small clinic that's located at our hospital campus. And it is staffed by a nurse practitioner, an RN, and a medical assistant. And we also have a physician advisor. And then we have our existing clinic management staff that manages this clinic. But this was a clinic that was established in part to make sure that we could eventually grow a rural health clinic on our hospital campus. But as it relates to working with employers, we were working with ourselves. In other words, this was a clinic that was designed to support any of our own employees who were on our health plan or were accessed our own providers. If we couldn't get into one of those four clinics, we could go here. It was sort of like an overflow clinic to start out with. So as we started that out, we'd established that it's a rural health clinic. We were there in order to improve access for our own employees. But then a local school district approached us and said, how can we work together so that our staff who are covered under our health plan don't have to go to urgent care, which is more expensive. And part of the reason they were going to urgent care is because there is another primary care clinic in town that we partner very closely with, but they're independent. Um, they were having issues just seeing all the patients because they had providers retire and they just didn't have as many providers. COVID made things challenging. So what they would end up doing is getting a call from folks about getting in, and they'd say, go to urgent care. Well, now when you went to urgent care, you were raising the cost of care. So the question is how could we use our campus clinic to create kind of a near site arrangement where school district employees or their dependents could call, schedule a same day appointment, and come in for a set rate to get care. Typically, these were, this was a uh, a it was a menu of symptoms like you've all probably heard about at CVS or Walgreens, that sort of thing, where it's you can't be seen for everything. There's a limit, and apologize for that. And as a so the school employee calls, they get scheduled, they come in, they see Laura, who you saw in the picture, or there's a telemedicine visit, and they get their care, and then we record that. And then at the end of the month, we send the school a bill for a set per visit rate. The goals, again, for this relationship with that employer was to make sure that they had access without having to go to the higher cost of care, place our emergency/urgent care room. That they were, when they met with Laura to have that care, we take that opportunity to remind them to maintain that relationship with their primary care physician wherever they may be, but we're here to help in that period of time, and then reconnect them with their primary care physician so that the use of their access to annual wellness visits would go up from the 38% that was there. We do not have the latest or the what their percentage is now. We're hoping it goes up. We are not 100% sure if it will. If it has yet, I should say. So that's what we call our health hub. We're working with one employer. We're now talking to another employer, local employer, that wants to access the health hub as essentially it's a near site clinic that it only takes care of acute situations. And we are trying not to destroy or circumvent the primary care physician relationship, but we do know that access is an issue. Oops, sorry. So our next steps is in 2 weeks when we meet with the school district and their benefit advisor about this particular program. Because here's what I will tell you. Again, my apologies for things ringing in. We priced the per visit cost lower than what our actual costs were. We kind of had a feeling that might happen. And the reason is because we added lab tests into the per visit price. Now, if somebody came in and needed to get an X-ray, that would kick into their insurance plan. So what we are proposing to do is have the per visit price remain the same, but if a lab is required, that would then go to their insurer. And I will tell you what we learned is that when the school district employees said, "Oh, it's just free, the school's paying for it," they wanted every lab test, they wanted a fourplex and everything like that. And it was not it didn't work well. And so we want to make it so that there is some skin in the game for the patient when they come in, they get a visit that's a set price and that's covered by the school. But then if there's anything else ordered on top of that, a urine screen, a swab, or anything like that, that would be charged to their employer. So, I'm sorry, their insurance plan. So we are looking at that. We are looking at what diagnoses that we are limiting this program to. I talked about the lab tests that are not free. And then, of course, we're talking about expanding this program. And the idea is that we're trying to improve access and trying to provide their care at a lower cost for both them and for us. So that the other things that we're working on, there are three things that I'd like to just close with. So you're probably familiar with what bundled pricing is. It's where you look at typically it's a surgical procedure, and you say that you offer it as a bundled price. We are doing that um, for a third-party administrator and a repricer who works with self-funded organizations. So uh, they really like to see bundled prices, and we are just about to negotiate final bundle prices for about 60 surgical procedures. Um, Essentially, what happens in that situation is if you can do that, that steerage of patients in from those employers, because there's predictability around what the price is, will actually increase volume. That's the concept. The other thing that we're talking to a couple of companies about as they go into the self-funded land, because they're coming off an indemnity plan that just keeps escalating, and they're going to self-funded, is near site clinics, a direct primary care clinic. We have done a small one in the past, and we no longer do that one, but we are just approached by another company that they would like to explore that. So we are looking into providing that, especially to self-funded employers, so that they have a captive population that we work with, especially when it comes to chronic medical conditions, and making sure they have annual wellness visits. And we also have a behavioral health component to build into that. So that's another area that we are just starting to work on. And then one that we haven't even really started with, but we have kind of in our starry-eyed dreams, is to see what we could do with very small employers. I'm talking about 2 or 3 people in a small business, maybe a husband and a wife and one other person. Well, they are not able to oftentimes buy insurance, or if they do, it's something off the exchange that's quite expensive, or maybe it's cheap, but it really is only for catastrophic. So could we create a direct payment plan for primary care, kind of like the Health Hub stuff I talked about, but possibly it involves a guaranteed annual wellness visit, which the Health Hub does not do, and maybe 2 visits or something like that. How could we make it so that we're not spending as much money for preventative care and for primary care, and we just create that direct relationship? There are certain things they have to watch out for that I'm sort of learning as I go around, taking risk and not, kind of like acting like an insurer. We don't hold an insurance license, so we can't exactly do that. But there are certain things we can do if it's a set and defined set of services, and you can provide that. So we're going to look into that. So these are uh, things that are in operation, and in our outlook over the next probably 12 to 18 months around what we can do to connect with the employers in our area to make sure that they have access to the healthcare. And the idea, as Marie was pointing out, there's mutually beneficial arrangements to keeping our organization healthy and going, and as well as giving the local employers access to healthcare without having to leave town. So with that, I will close, and I think we're going to be wanting to talk about or field questions.
Yeah, thank you both so much for presenting. Well, if anyone wants to put questions in the Q&A, we'll be checking that.
Molly, there is one thing that when Marie was talking, that I had as an example unrelated to the things I shared, but one thing that we did with a local company was, now they happen to be a sports medicine company, like they make products. But we are connecting them with our GPO, our group purchasing organization. My point is are there relationships in your market where somebody maybe makes something that if you belong to a group purchasing organization, could you connect them? I know of one organization that builds reception desks that are bulletproof, as an example. And that's a big thing in healthcare to have protection. And we put them in touch with a group purchasing organization in case they might be, it opens up a new market. My point is group purchasing organizations may offer new markets to small manufacturers. So I just lay that out there as another example.
That's great. Thank you. Well, let me check if there are any other questions. And that reminds me too, if you have questions or maybe comments, stories you want to share, maybe kind of bounce off pens, that would be great too.
I see one in the
Molly,
Q&A.
there is.
What is the utilization of the community center
Yeah.
of the new
Yeah.
facility? I think that was wonderful. So I can talk a little bit about what I know, but if you want to, I can also, if you follow up, put you in direct contact with the leaders from that organization. So
If you, Marie, if you'll go ahead and respond to that one, and then I'll read the next one to you
yeah.
for everybody to hear.
So the way that that community building is or room within the clinic is set up is it can be accessed like after hours, et cetera, through kind of like a fob. So people can utilize it for like nighttime meetings, weekend meetings, et cetera, not just when the clinic is open. That was important to them. There also is like a tiny little micro green space outside of the building that has these like really neat solar phone chargers. So like just encouraging people to spend time in downtown, right? So they were really intentional and kind of like place-based design and thinking about one of the goals of that construction project was like more people in downtown, more economic activity in this small community. And I think, we've seen some of our organizations do that through having just like really strong food service programs where like ladies lunch groups, right, will come in and utilize their cafe, like any way that your organization can do what you're already doing in a way that bolsters local economic activity, I think is wonderful. Ken, I don't know if you can see this, but the second question has
You'll
to do
hold
with
on 1 second, Marie. I'll be vetting these. I'll read them
Okay.
out loud. But also I wanted to say, Marie, I appreciate these really practical ideas that you all provided. Really fascinating and gets us thinking differently, I think. The next question, though, is what resources do you utilize to ensure compliance with insurance payers, et cetera, as you are setting up these direct primary care models?
Yeah, I think that's directed at me. So a couple of responses on that. The first thing is we consult with our attorney in any relationship that we have with regard to insurance requirements. Now, the direct primary care model is the only ones that we are familiar with and that we've worked with working with companies that are self-funded and they fit under ERISA. And so therefore we tend not to have any insurance issues around that because these are self-funded employers who have a little bit more flexibility, is my understanding. In fact, with the one that we're talking to, the insurance plans that they work with actually encourage direct primary care clinics because it helps manage costs or can help manage costs. So the only resource, though, that we've been working with is we have a couple of attorneys that are expert in this area, and we've followed up with them on some questions that we have. I hope that answers the question.
Marie, I think you wanted to chime in as well.
No, I don't have anything to add. I just feel like
Oh,
this
okay.
is an emerging area, right, where our local employers, we hear recurringly the kind of precipitous rise in healthcare costs is one of their big challenges as employers. And any way that we can partner with them as healthcare organizations to, one, stop the outsourcing of care, because I think what often happens when people are seeing that increased cost of care is they're tempted to write contract with like one specific MRI provider, one specific rehab provider, and that's just money leaving your community. So if we can be proactive partners in keeping low cost, high quality, easily accessible care within our communities, that's a huge benefit to our employers who are kind of battling that rising cost and a benefit to our healthcare organization. So I think it's a little intimidating and takes some creative thinking, but Stock Prairie is not the only organization within our cooperative thinking about this. There's multiple others that are exploring it. I don't know that anyone has like the perfect model that's cracked the nut, but I think it's really necessary to kind of keep our local economies healthy.
Absolutely. Okay. All right. Thank you. Doesn't look like, Molly, there are any other questions in the Q&A, so I will hand it back over to you to wrap up.
Thank you. Yeah, thank you for everyone that put questions in the chat. We appreciate it. Thank you, Marie and Ken, for presenting. Again, this was really great material. For those of you in the audience, we'll be sending out copy of the slides and a recording, so keep an eye out for that. If you have any questions, reach out. There will also be an evaluation survey if you'd like to give us some feedback on what you thought today. So thank you, everyone. Enjoy the rest of your day.